Assalamualaikum and good morning to Madam Asma. Thank you for being here today. My name is Musliana binti Ismail and I am going to present a case study on homozygous mutation of achondroplasia in children with C113HG2A variant in FGFR3 gene. This case study delves into the clinical implications and unique genetic presentation associated with this rare condition. This case study explored the clinical presentation and management of a patient with homozygous achondroplasia, a genetic disorder affecting bone growth with a specific focus on the C113HG2A mutation. My presentation will unfold as follows: introduction, genetic of achondroplasia, diagnostic workup, discussions, conclusion, and references. As for introduction, achondroplasia is the most common form of skeletal dysplasia in humans, accounting for approximately 90% of non-dwarfism. It has a global prevalence of approximately 1 in 25,000 live births. Achondroplasia is characterized by rhizomelic limb shortening, macrocephaly, and distinctive facial features. Achondroplasia is a genetic disorder that causes abnormal bone growth in the arms and legs. Achondroplasia is caused by a mutation in the fibroblast growth factor receptor 3 (FGFR3) gene. Most cases of achondroplasia, about 80%, are not inherited from a parent with the condition. There is no cure for achondroplasia, but treatment can help manage the symptoms and improve quality of life. Achondroplasia, the most common form of short-limb dwarfism, finds its root cause in a genetic mutation. This mutation occurs within a specific gene called fibroblast growth factor receptor 3 or FGFR3. Interestingly, mutations in this gene are the only known causes responsible for achondroplasia. This also allows for a simpler and more precise diagnosis through targeted mutational analysis. The inheritance pattern of achondroplasia follows an autosomal dominant pattern. This means that only one copy of the mutated gene is enough to trigger the condition. It's important to note that roughly 80% of achondroplasia cases occur in individuals born to parents of average age, meaning the mutation arose spontaneously in the child's gene. The remaining 20% inherit the mutation from one or both affected parents. While uncommon individuals can inherit two copies of the mutated gene, resulting in a condition known as homozygous achondroplasia. Compared to the more common heterozygous form, homozygous achondroplasia typically present with a more severe set of characteristics. Meet a baby, an 18-days-old male infant currently under care in the neonatal intensive care unit at Hospital Sultan Abdul Halim, Sungai Petani, Kedah. This baby was born prematurely at 31 weeks and presents with clinical features suggestive of achondroplasia. Both of these baby parents have been diagnosed with achondroplasia, indicating a familial genetic predisposition to the condition. The pedigree chart shows achondroplasia spanning 3 generations within a family. The affected individual is an 18-days-old male, indicated by the arrow pointing to him. Both parents are affected, thus suggesting the mutation for achondroplasia was inherited from a parent rather than arising spontaneously in the patients. The parents have 3 children, 2 male, 1 from it has passed away, and 1 daughter 8 years old is affected with achondroplasia. This indicates that the parent passed the mutation for achondroplasia to their children. There is a 50% chance that each of the affected children carries the achondroplasia mutation and could pass it to their own children. Achondroplasia is an autosomal dominant genetic disorder, meaning that only one copy of the mutated gene is necessary to cause achondroplasia. Next, diagnostic workup. Radiographic findings further supported the diagnosis, showing skeletal abnormalities consistent with the conditions. From the figure 3, RFLP pattern for the normal control A1 was represented by a single band, while 3 bands were observed for the mutant allele control for heterozygous A2 of FGFR3 alleles. After digestion with SFC1, 3 bands were identified. The homozygous patient sample A4 of FGFR3 alleles after digestion with SFC1 presented 2 bands. A5 was a blank. RFLP analysis confirmed homozygous mutation, providing a definitive diagnosis. However, the patient sample to be confirmed with the Sanger sequencing method, as this is the first case of homozygous C113HG2A using RFLP method. From the figure 4, the electropyrogram display the nucleotide A, T, C, and G represented by green, red, blue, and black colors. Single peak in green was observed, indicating that the sample was homozygous. R indicate that an amino acid changes to arginine at position 1138. To confirm this mutation, Sanger sequencing method was carried out for the exon 9 only. From this report, it can be concluded that the patient carried the mutation of homozygous C113HG2A on exon 9 in the FGFR3 gene. The clear association between the identified FGFR3 mutation and the patient's clinical presentation served to solidify the cause of his illness. Next is the discussion. Given the rarity and severity of homozygous achondroplasia, genetic testing was crucial for confirming the diagnosis and ruling out other potential conditions. The identification of the homozygous C113HG2A mutation in the FGFR3 gene provided a definitive diagnosis, enabling a focused and effective management plan. This case is particularly relevant to its unique genetic presentation. While achondroplasia is typically caused by heterozygous mutations, the patient described here has a homozygous C113HG2A mutation in the FGFR3 gene inherited from both parents. This rare genetic profile is associated with a much more severe phenotype, making this case significant for advancing our understanding of homozygous achondroplasia and its clinical implications. The patient's survival past the neonatal period, typically associated with lethal alleles, highlight the importance of early diagnosis and immediate intervention strategies. The comprehensive management plan involving a multidisciplinary team of specialists underscored the importance of specialist care in improving outcomes for patients with rare genetic disorder. Genetic testing plays a vital role in the diagnosis and management of rare genetic conditions like homozygous achondroplasia. The severe skeletal dysplasia symptoms observed in this case, such as macrocephaly, rhizomelic limb shortening, and distinctive facial features, necessitate immediate genetic testing to accurately identify the underlying cause. The identification of the homozygous C113HG2A mutation in the FGFR3 gene provided a definitive diagnosis, allowing for a focused and effective management plan. Furthermore, this case highlights the need for personalized care strategies tailored to the patient's unique genetic profile. A comprehensive management plan involving a multidisciplinary team of pediatricians, geneticists, and orthopedic specialists was essential in addressing the specific challenges posed by this rare genetic profile. Personalized care strategies are crucial in improving the outcomes and quality of life for patients with rare genetic disorders, enabling healthcare providers to develop targeted interventions that consider the patient's unique genetic and clinical characteristics. Looking to the future, there are two critical areas that hold promise for improving outcomes for patients with severe genetic disorders like homozygous achondroplasia. Firstly, advanced in genetic testing are paramount. The increasing availability and accuracy of genetic testing can facilitate early and more precise diagnosis. This in turn allows for timely and targeted interventions, which are essential for managing conditions that have severe phenotypic manifestations. Secondly, ongoing research into molecular mechanism and potential therapeutic intervention hold great promise. Understanding the underlying molecular pathways can lead to the development of novel treatments that could significantly improve the prognosis for patients with severe form of achondroplasia. Additionally, the role of comprehensive care teams in managing complex genetic disorder cannot be overstated. The involvement of the multidisciplinary team ensures that all aspects of the patient health are addressed, from immediate medical needs to long-term management strategies. This holistic approach is essential for improving the quality of life and outcomes for patients with rare genetic conditions like homozygous achondroplasia. As for the conclusion, this study case highlights the clinical significance of homozygous achondroplasia, a rare and severe form of skeletal dysplasia resulting from the homozygous C113HG2A mutation in the FGFR3 gene. The patient presented with severe skeletal abnormalities and typical features of achondroplasia confirmed through genetic testing. Unique due to the patient's survival past the neonatal period, this case underscores the importance of early and accurate genetic diagnosis and a personalized management approach. Documenting this representation contributes valuable insight into the clinical manifestation and management of homozygous achondroplasia, emphasizing the necessity of a multidisciplinary approach. It aims to increase awareness among healthcare providers about the potential for severe phenotypic manifestations and the critical role of genetic testing in guiding treatment strategies. This case not only adds to the existing body of knowledge on achondroplasia but also highlights the importance of genetic testing and personalized medicine in improving patient outcomes. Continued research and documentation of similar cases are essential to enhance our understanding and management of these rare and severe genetic conditions. Next is the reference, and thank you for your attention.